Hello, everyone. We'll just give it another 10 seconds and then we'll get started. Okay, well, hello and welcome to What Women and Clinicians Should Know About Cognitive Health. Now, June is Alzheimer's and Brain Awareness Month, making it a perfect time to have a webinar on this critical issue. I'm Jess Steyer, CEO and founder of Unbiased Science and host of the Unbiased Science podcast. We're devoted to objective, critical appraisal of available evidence on science and health-related topics relevant to listeners' daily lives. I'm a public health expert specializing in science and communication, and I'm so excited to continue the conversation that we started on May 27th, on the May 27th episode of the podcast, featuring two of our speakers today. I'll introduce them in just one moment, and we'll share the link to that episode in the chat. It should be there in just a second. Now, I learned so much from that discussion. Alzheimer's is the most common form of dementia, which is a progressive disease that gradually damages the brain and erodes memory, thinking, and the ability to handle everyday life. What I didn't realize is that women carry more of this than, again, most of us realize. Almost 2/3 of Americans living with Alzheimer's are women, and women also make up most of the unpaid caregivers looking after someone with dementia. So women are both more likely to develop the disease and more likely to be the ones managing it in their families. Researchers are still untangling how much of the higher rate comes down to women living longer versus biological factors like hormones. We're going to talk about all of this, but the gap is real and it shapes who this disease affects most. So today we're going to talk about why women, what to watch for, diagnostic gaps, caregiving, prevention and treatment, and practical next steps. Of course, we're hoping that this will be a highly interactive event, so please don't be shy. We want to hear from you in the audience. We'll have a poll and an opportunity to weigh in, and we'll have time reserved for a Q&A at the end. So please use the Q&A feature in Zoom to submit questions for our amazing speakers throughout the event. And if we don't get to your question, we will do our best to answer them offline. All right, let's introduce our amazing panel. So we're thrilled to be joined by a panel of esteemed speakers. So first off, Dr. Neelam Agarwal is a cognitive neurologist, clinical trial leader, and professor at Rush University Medical Center, whose work focuses on women's brain health, dementia prevention, cardiovascular health, and stroke recovery. She's also a leader in advancing women in medicine, serving as the first Chief Diversity and Inclusion Officer for the American Medical Women's Association, and helping drive national efforts to expand equitable participation in Alzheimer's research. Leah Fisher is a writer, psychotherapist, and author of My Marriage Sabbatical, who shares her experiences with solo travel, marriage, and living with mild cognitive impairment, MCI, to offer insights on resilience, relationships, and facing an elevated Alzheimer's risk with curiosity and compassion. Kelly Cook serves as an associate clinical professor at Emory University and nurse practitioner at the Emory Brain Health Center with expertise in migraine, headache disorders, chronic pain, neuroscience, and brain health. And last but not least, Meryl Comer is a pioneering Alzheimer's advocate whose leadership is rooted in 24 years of caregiving for both her husband and her mother with Alzheimer's disease. A former journalist and New York Times bestselling author, she co-founded Us Against Alzheimer's and its women's network and helped lead major national Alzheimer's initiatives focused on women's brain health, early diagnosis, research, and public policy. So before we begin the panel discussion, we want to hear from you in the audience. Alzheimer's disease and cognitive health can touch people's lives in many different ways, as clinicians, as patients, as caregivers, family members, advocates, or all of the above. To help us understand who's in the room today and where this topic shows up for you, you should see a quick poll on your screen if you're able to just complete that now. And I should be able to see results pop up in just a second if technology goes my way today. We'll give it another second. While we're doing that, I see a comment in the chat here. Stacked panel, indeed. We're going to learn a lot from these ladies today. Okay, I am not. Oh, here we go. Here come the results, I think. Possibly. Okay, well, I'm not seeing the results, but I'm going to go ahead and assume that we have a mix, as I said, of clinicians, patients, caregivers, and advocates, each seeing different pieces of the same problem. And certainly closing the gap is going to require all of those perspectives. So let's get into this. Leah, I'd love to start with you. So, can you please walk us through your experiences and what were the early signals that something might be going on?
Okay, happy to do so. I should explain that I'm a tidy person. I hang on to my stuff and I show up for appointments on time. In 2 days' time, I missed an appointment altogether and I showed up for another one a week early. So that wasn't me. I found myself leaving clothing behind, my best sweater coat. And again, that wasn't me. It moved on over time to having trouble um, coming up with words and names. And it's interesting because at the early stages of cognitive impairment, one looks like everybody else who's getting old. And people will say, oh, I do the same thing. That's just like me. Don't worry about it. Um, and it stops looking the same at a certain point. For people who don't have cognitive impairment, that ditziness stays level. And for someone who does have impairment, it begins to slide down, so it's worse and worse to the point where I will lose my train of thought mid thought. Um, there'll be something important I need to look up on the computer. I need the phone number for the doctor whose appointment I need to reschedule. By the time I've lifted the lid on my laptop, I have no recollection of what it was I was planning to do.
And so those signs, that's what prompted you to go seek medical care?
Early in that sequence, um, I knew something was amiss. And I had also heard of the value of getting a baseline study where you find out what cognitive level you're at early on and then get to see whether it stays level or whether it progresses. So for the last 9 years, I got my baseline and I've been going back every year. Um, and it stayed quite level for the first few years. And now in the last 3 or 4 years, it's begun dipping.
Thank you for sharing that. I know in just a little bit, we're going to hear from some of the clinicians about diagnostics and screening. Meryl, I'd love to turn to you. If I'm not mistaken, you were caretaker for your husband and your mother with Alzheimer's. Can you share a little bit about your experience from a caretaker perspective, what that was like?
Jess, I'd love to, but I want to just say to Leah, I have such great admiration for her stepping forward. I think it's very important for those who are living in the earlier stages of the disease to show what's possible for living well in the disease. I'll take you down memory lane. Back then, 24 years ago, go to 2021. Alzheimer's was steeped in stigma, so there no treatment, no cure. My husband was a physician researcher, chief of hemonc at NIH, in his late 50s, misdiagnosed for 5 years. Pernicious anemia, he was prematurely gray, mad cow's disease, because he had just been to a conference in England. In denial, he didn't fit the mold, too young, too smart, too accomplished. And finally, after 2 months in a hospital for evaluation, he was turned back to me with a diagnosis of Alzheimer's, but too dangerous to come home. No facility would take him, so I left my career to care for him at home, and then I made it up as I went along. Fast forward to today, the care partner is still treated as invisible. So you're handed a diagnosis with a Lovabon, with no real counsel of what comes next. And we're talking about 2026 when you read these books from other caregivers with the same issue. So it's a real problem. My advice from one doctor was call 911 if he gets too dangerous. And I say, excuse me, families try to take care of loved ones at home, but close to 90% will, and I'm sure Neelam will share it, exhibit some form of psychosis that makes it difficult to keep them at home. And they move to a facility and then they get kicked out. But my plea to clinicians and the specialists who are listening, avoid the paternalism of not telling a patient and a family that they have the disease because you don't want to depress them. Tell it like it is. We need that information.
Wow, that's so powerful. So actually speaking, you're talking about guidance for clinicians. Let's speak to the clinicians right now. I'm curious, Callie, can you describe how this shows up in clinic visits and how do you recommend that providers ask about cognitive change without creating shame or fear in patients like Meryl just described?
Yeah, thanks so much, Jess, for that question. And thanks to Leah and Meryl for sharing their experiences. I think that's eye-opening, and we really need to listen and think about how healthcare can be improved to really meet the needs of patients and care partners. But I have to say, when I see patients, I rarely see someone present with cognitive complaints as the cause of the visit. Typically, the cognitive complaints are discovered after asking questions. I see a lot of patients present with migraine, and brain fog can be a common symptom of the post-stromal of migraine. So it comes up frequently. But as a clinician, my job is to determine, is this related to the migraine episode? Can this be treated with migraine treatment? Or do we need to intervene further? And I think listening and really trying to meet the patient where they are, asking those important questions about how this cognitive symptom is affecting their life is incredibly important. We want to know if this is acute and kind of short-lived or if this is ongoing. So we don't want to just say, oh, you're stressed out, or this isn't something to worry about, or I feel like that sometimes too. These complaints really need to be explored and then determined if they're related to a condition that the patient may already have, or if we need additional testing.
Hmm. So it sounds like recognizing symptoms is only the first step. The next step is making sure that those concerns are then taken seriously, evaluated appropriately, and then connected to the right next steps. So I think maybe we could shift gears now to turn to that diagnostic gap that we were talking about and what it will take to close it, especially for women. So, Dr. Agarwal, let's dig in further about why diagnosing Alzheimer's disease and cognitive decline can be challenging. So, can you describe why women's cognitive symptoms may be missed or minimized by clinicians? And are there certain symptoms that women should be looking out for and warrant further evaluation from a clinician?
Yeah, I think just before I answer that question, I just wanted to mention exactly what Callie, and I agree with her totally. People don't just drop in and really at times say, I have a memory issue. There are so many clues that are dropped daily in the healthcare system that there may be an issue with a patient And I'm saying this in any office. This is not just primary care. This is not just neurology. This is happening in GI right now. I'm in cardiology for many years, and had the privilege of being in cardiology at the Heart Center for Women with Doctors Vogman and Brown, seeing how cardiology patients are dropping hints that their memory is not the way it used to be by missed doctor visits. What Leah said, leaving things, and we are not picking up on that. So first of all, for the clinicians listening, people will drop little hints. Things are not quite right. It's your job then to say, okay, let's figure it out. For a women's perspective, it gets brushed. We see the doctors more often. We talk more often. We're more vocal about some of our concerns, issues, and we carry a lot on the plate. And that is what kind of muddles up everything. Oh, again, you have too much going on. You're stressed. You're low on iron, all these kinds of things, but not really peeling it back. Like, wait a minute, there's an underlying issue going on here. Let us talk about the cognitive issues, not about what we think initially is part of lifestyle right off the bat, because that's where people get lost in the system. And I think on the last podcast, I talked about how long it takes from when somebody enters in the system, our health system, to an actual diagnosis is crazy. It's crazy. It's years. It's years. You heard it from Meryl, from her husband, but even now it's like over a year. And if I look at the timeline, I'm like, wow, so many hints were dropped that this is not what they were thinking about. How can we miss it? So for women, because we have really strong verbal ability, we're able to articulate well. That is a great masquerader. And you see it in clinics all the time. How are you doing, Mrs. So-and-so? Oh, great. How are you? And I can get a MOCA score coming in at 12. Oh, I can't believe it. I cannot believe that they can't draw a clock, but they were sitting talking to me for 30 minutes, 15 minutes. Women tend to use language very well. So we are missing earliest signs because it's being covered up, because we're able to compensate. The other problem with women, and it's not actually a problem though, our lifespan, as you said, is increasing, but we also enter premenopause, perimenopause, menopause. And in the past, that was kind of the shutdown stage. Okay, things are going to get slower. And these things happen in menopause, not understanding the implications of hormone imbalances and what that does to the brain and how you think and how you can perform. So we're in that stage where it's kind of now, well, that's not really, maybe you should talk to your OB-GYN about this. And then it gets shuttled off again away from brain health to OB. And then you can see the pattern occurring again of circling the healthcare system. So we have that. And then, of course, the caregiving situation, which Meryl knows all too well. The stress that's related to that, not knowing what to do. And that is now making everything get more muddled. So for women, the roles, our hormones, and the fact that we have this resilience really slows down the diagnosis of what really we should be talking about, what's really happening. And is this progressive or not? And what should we investigate?
So I think it's great that you emphasize that clinicians of all types should be doing a lot of listening, right?
Absolutely.
But are there certain things that clinicians, again, of all types, should be asking specifically or screening for or referring patients to in order to learn more about diagnosing cognitive health issues specifically?
Okay, so one thing, and I want to hear the panelists here, but one thing I would say, just remember this: when anyone gets asked about how are you doing, how are you thinking at certain ages, there is fear from the patient, most likely. You're trying to take something from me. I'm going to lose my independence. There's a fear that I'm not giving you something in return for that question. I'm trying to take something away for a lot of people. So they will not tell you the right answer. Hey, everything's fine. So this is where those other clues come in. So for example, missed appointments, I would open up to a patient, yeah, so I heard from, I heard from the nurses that, yeah, you came a week earlier. So what was going on? People then, oh, I couldn't believe it. I got turned around. I can't believe that. Never happens. Oh, okay. that's your door into understanding how often, when did it happen? How is it bothersome? Oh, well, so then how has your memory been? How have you been thinking about things? Oh, I'm forgetting. Okay, well, talk to me about that. That's your door in to get into the cognitive piece. And then once people feel comfortable that you're trying to keep them independent, they may open up way more than just saying, how's your memory?
Hmm. Kelly, I see you nodding along as a fellow clinician. It sounds like you're in agreement. So, Kelly, you're spending time training the next generation of nurses and NPs right now. So I'm curious, what are you teaching and what are you seeing in these emerging clinicians about approaching conversations about this, about cognitive change?
Yeah, this is an excellent question. Nursing when we think about nursing practice, we think about holistic practice. So we really want to think about the entire patient. And most generalists aren't, or excuse me, most nurses aren't specialized. They're going to have a general practice. So they're going to not see someone come in and think, oh, I'm just dealing with X body system. They're going to be thinking about kind of the whole patient, which is really helpful because when we ask those questions about missed visits or trouble preparing food or forgetting how to work the microwave or things like that, we get a little bit more because there's a relationship already there. And I think that's one benefit of the nurse. When you come into a hospital or a clinical setting, they're really the first person you're going to interact with. And you're going to give a lot of information to that nurse that you might not be willing to give the person who's actually doing the diagnosing for fear that something's going to be taken away. So when we're talking with our students and future nurses, we really want to think about that relationship building and how we build trust and how we support that trust, how we talk with patients about interventions that are going to help them to live. And that gets to the stigma of many of these chronic diseases like Alzheimer's. You can live with Alzheimer's. There are opportunities, there are treatments, there are things that can allow life to continue and you to live the way you want to. And we want to catch that early so we can enable those things to happen. So we can set you up for success with your care partners and with treatment. So really it goes back to building relationships and creating a space where the patient feels welcome to engage with you and tell you a little bit more about their life and what's going on.
Hmm. So speaking of that clinician-patient relationship, Leah, thank you again for sharing about your experience receiving your MCI diagnosis. We have a lot of clinicians listening right now.
Mhm.
Do you have any practical suggestions for them, hearing patient concerns for the first time? Oh, Leah, you're muted.
I think the best way to respond to that, at least at the beginning, is to describe a good experience of receiving a diagnosis and treatment. So I was at UCSF, the University of California at San Francisco, and as I mentioned, I wanted a baseline because what was happening didn't feel in character with who I'd been before. Couple of things that I found really helpful. So I went to get testing, and during the same visit, I got responses from the neurologist. Someone else did the testing, and several hours worth. And then I met the neurologist who was going to give me feedback. It was very nice not to have to wait and wonder. Something else that was really helpful, they like to speak to a family member to find out whether there's a match between what the person is saying, the patient, and a family member. My doctor called my daughter while I was in the room and let me be in on that, listen in on that conversation. It makes such a difference to not have things done behind your back. So that was also helpful. My neurologist answered my emails either the same day or early the next day. And I finally asked him if he was really a physician, because that seemed so out of character. He also told me about clinical trials and invited me to be involved with those. And I did go on to get amyloid and tau screenings. Not good news in either case. But eventually, they had a psychologist on staff who would explain the results to patients. And I can't tell you how helpful that was. Their job wasn't to find out what was going on inside your brain, it was to explain what they found out to the person whose brain it was. And I just found that enormously helpful. It was the clearest explanation I've ever had. And then unfortunately, he went on to do other things, and that role wasn't filled again. But I thought it was a really helpful and important one.
Wow, clinicians take note. Those were some really helpful, concrete pointers that I think would be great. Maybe we can summarize and share with folks after this webinar. Meryl, I have a question for you because you do so much advocacy in this space. I'm curious, what are your priorities right now, specifically around screening and diagnostic access, and where do you see the greatest opportunities for change or improvement?
Well, I'm a big one that there's power in knowledge. And I really believe that there are now treatment options. They didn't exist before. My mother at 85 was just labeled with Alzheimer's. She wasn't tested properly to see what she had because the doctors, let's be honest and respectful, they're dealing with other issues that a loved one might have. So it's hard, and you have loved ones in denial. So intervention has to come early, and you now have these blood-based biomarkers that really are as accurate as the costly PET scans, because that was the turnoff and why people didn't get them. So my advocacy is really about the next generation of caregivers. Because I am very concerned about what's happening to them. Um, you know, it's a woman's issue. And the current estimates on unpaid care, $340 billion a year.
Oh my gosh.
Yeah, oh my gosh. And that is the unpaid 18 billion hours of unpaid care, 11 million caregivers. Now, the average caregiver, 40 to 65. So you're in your prime, you're taking care of a young family, you're taking care of an older parent. And I mean, I have to tell you, this becomes an economic and gender equity issue.
Big time.
Many women deplete their
Big time.
savings. We neglect our own health. And we carry that long tail consequence of caregiving into later life. We are statistically 6 times more likely to get dementia ourselves due to our own brand of hypervigilance. It's the intensity over years of care, and it can stretch from 3 years to 21 years. I'm an anomaly with 24, but that's what's going on. So you're really working to improve a system that relies on the sacrifice of unpaid care of women who are in their prime. And at the back end, they're being hurt in so many different ways. So I'm all about the next generation of the caregiver and early diagnosis. I had my genetics, and what you learn is that if it's on the maternal side, your risk profile is higher. So I opened my results, and I thought I was going to drop dead of a heart attack just because of the intensity of care at home. I ended up being a 3-4. So my profile is higher. And what does that mean? It means that I am doing everything on the brain health side until the science catches up.
Right.
So
Right.
that is my focus, and we have been working on the Change Act. Advocacy is a long time game. 2021, the Change Act which was looking at prevention, early detection, better coordination for families, reintroduced in 2023. It has been reintroduced one more time, bipartisan, trying to uh, get this done. But it would require that physicians begin to use what the NIH prescribes as the right medical testing to be used. So it's all complicated. It all takes a long time, but those are the areas for advocacy.
Wow. Thank you so much for your advocacy, Meryl. I see some questions coming through, and I think it's a good reminder for folks. We're about midway through today's webinar. Please use the Q&A function. Leave your questions. I see some. I have noted them. We'll come back to them in just a little bit. Let's talk next about prevention, risk reduction, and treatment. So, Leah, if I can turn back to you, you just told us just before your message for clinicians, but I wonder for those listening who who might be going through testing or diagnosis and treatment as patients, would you share any messages with them?
I think I'd start with a message about them that different people have different responses to news that could be bad news. There are people who are intensely curious, and if somebody knows it about them, they want to know it too. There are other people who are at the very opposite end of the spectrum. I'd rather save bad news for later, or I'd rather not know it at all. It's very unlikely that a medical professional is going to change those inherent ways of dealing with life. And so the next best thing is to understand how your patient does and to base what you share with them on who they are, not who you are. Easier for a primary care doctor who's been connected with that person for a long time, but you can get a feel. You put out something mild and then find out whether your patient sits back or leans forward.
Dr. Agarwal, did I see you go off mute and want to jump in?
I do want to echo what Leah said, because this was a theme that we talked about earlier too. The more you see people, and again, these are for the clinicians, all of us have different reads on people. And I have to say, these visit times are so short now that it also makes it harder to get a read on someone, about how much they want to know. I think one way to handle, if you start through this discussion about how much do you want to know, I go through the process first before jumping into the testing. And people really have said to me, thank you. I'm just going to talk to you about process so you understand how the medical field is thinking about this and what's the next step. I think I always joke, my t-shirt, the now what? Okay, you did the testing. Meryl's talking about the blood-based biomarkers, which again are terrific, but then it's the now what? And the now what comes really quick. Okay, like Leah got testing and got neuropsych testing done. The now what was, what are my results? She got her results, you see? And I think because of how things have progressed in our field, which is fantastic, but the speed at which people are wanting things, we have to take pause. Some people don't realize how short it can be or how long it can be. So I do go through the process as part of that advocacy and educating people. Here's how we think about it. Here's what we know. Here's what we don't know. And these tests can sometimes come up indeterminate. Now what? Are
Mhm.
you okay with that? I have had multiple patients and families come in and say, oh my gosh, nervous wreck after all this. We just can't live like this. If
Right.
we would have known that this would have caused so much anxiety, we would have never done it. And I'm, again, but then I've had other people saying, thank you for calling it. I've had women say that to me. Oh, thank you so much for calling it. And everybody in the room heard it. You called it, meaning I made a diagnosis because of the stress on the woman of trying to hide the problem when it couldn't be hidden. So I just want everyone to really, really think about what Leah said, that everybody's different, but that does not mean you skirt it under the rug and you don't approach this conversation. It's just the question of the speed at which people are able to handle things and be mindful of it and respect that. That's all. And I would like to hear what Callie thinks about that, Cal, because you're in the clinic talking about these things. How do what's your impression on Emory with this?
I totally second what you said. We have to have a plan. And part of the relationship, that I mentioned earlier with the patient is this is bidirectional. So they have to be involved in the plan. They have to agree to the plan. So I completely, I second everything that you said. The patient is instrumental in how we move forward. And they're helping us to make that choice on what to do next and when to do it. So they're, having a plan is key and making sure everyone agrees with what we have set out to do and that that's documented. I really like to make sure that's included in my notes so that patients can, if they're alone, they can show it to their care partner later, or they can just pull it up and be like, oh, yes, this is what we said we wanted to do. And if they want to change their mind, we all change our mind.
Right.
So I'm welcome that, let's just talk about it and let's change our plan. We can do that.
Right. And then the adult kids are happy because they said, okay, I get it. Because sometimes the adult children want to move things at a really fast pace and not understanding the process and not saying that it can't be done, but I'm all about systems. And that's part of the advocacy. We got to get the systems in place here. We
So
have to get this.
can
Go
I
ahead,
give
Meryl.
2 examples, Jess? The
Please.
doctor said my husband might last 4 to 5 years. He was a wonderful doctor, never gave up on his patients, and I wasn't going to give up on him. 20 years later, the doctor sees me at a conference, surprised my husband is still alive, and shared in hindsight, well, I checked his records. He probably had frontal temporal dementia. And my reply was, I don't care what you call it. All right. My mother, again, simply labeled. I bring up the 2 incidents because today there are a growing documented number of mixed forms of dementia that have been missed in earlier diagnosis from Lewy body, vascular, frontal temporal, and now late that actually presents like Alzheimer's. So the research is advancing early cognition, but it's adding to the complexity of the public dialogue around the disease. So it's the stigma can just trend younger, and that's what we're also fighting against to help. You don't want to derail people in their prime, and that's what happened to my husband, 2 adults in their prime out of work, right?
Right.
These are huge societal issues we're not dealing with.
No, Meryl, and I'm so glad you brought up the economics because I remember I kept saying, and again, for our audience here, women, the glass ceiling isn't going to take you out. Caregiving is going to take you out. And I used to say that all the time. I remember, Meryl, and again, years ago, and people would be kind of looking at me like, what are you talking? I said, no, you don't see what I'm seeing. You lived it. You were living it. But I was seeing it day in and day out. The women coming in and saying to me, and when I'm asking the women who would see me, how are you doing, the caregiver, they started crying. And cry. And I said, here, sit here and we're going to get this out. Nobody ever asks me, I'm going to have to give up my job. And I kept saying, no, what can we do to keep you working? Because that is economics factoring in your family. And it never really is getting the traction as it is now because of the sheer numbers that you shared, Meryl, the volume of caregivers, the number of people caregiving, the grandchildren who are caregiving. I mean, these are things that it's not just make a diagnosis. This is a system that is being affected on multiple levels. So hearing patients talk about issues, doctors responding with their care teams and nurses, everybody has to be in on this. Everybody has to be in.
We also have to be very alert to a younger generation taking care of grandparents. They're being raised in the inner cities. Many are being raised by their grandparents.
Right.
And the emotional toll that it takes on a young person, I mean, we know as adults what it does to us. Think of a young person who has to go to school and then is charged with absenteeism. Excuse me? So it's so layered within our society attached to longevity now that it is, and for women, the professional damage is done, quite frankly. Any woman, I don't care what your age, stepping out when you had a child, it took you 2.5 years to try to get back to where you were. Caregiving just wipes that away.
Exactly.
So, yeah.
Exactly.
Now, I have a couple of clinical questions for both Dr. Agarwal and Callie. Maybe Dr. Agarwal, we're getting a lot of questions about prevention. So people wondering how much can they actually control throughout their life?
Oh, Callie, you're going to jump in on this. Yes. No. This is such a good question, and we've got to talk about this. There are so many risk factors that are important for brain health that are affecting your heart, something that's very important for me to talk about. Heart health is brain health. So let's get simple. Heart health is brain health. Whatever you hear about how to protect your heart, walking, exercise, diet, good nutrition, hydration, manage your stress, it all in the research has been shown to affect brain health. And that if you modify these factors to optimize them, I like to use the word optimize them, almost half of dementias could be prevented and or delayed. I mean, we have data from the Lancet article that is constantly being cited, and please read it. That goes into vision, it goes into hearing, it's now gone into prevention of head injuries, finally. That came in, but these are modifiable risk factors that take it to heart and your brain. Focus on those. That's prevention in a nutshell that I would say. And to really not just say it, do it. Really look at things. So Callie, over to you. Over to you.
Thank you so much. I love talking prevention because I agree. It is just incredibly important. And believe it or not, prevention starts in utero. Prevention starts before you're even born. The health of your mother, any maternal infections, that helps your brain health through your childhood, your young adulthood, your adulthood, midlife, and then as an older adult. All of that matters. It's vastly important. So we want to think about, how do we prevent infections? How do we make sure that you're active? Your grandchildren, your children, are they playing at least an hour a day? And are you exercising about 150 minutes a week? Those things matter so much. Are you able to get outside and see green trees? Do you have green space that you can be a part of and enjoy fresh air? Air quality is really important. We know to heart health, to brain health. So we want to think about, what are ways that we can affect our air pollution? How can we clean our air so that we're not creating more inflammation by what we breathe? We want to think about the foods we eat, high fiber foods, foods with lots of phytonutrients, eating the rainbow, that's a real thing. So you want to do all of those things. And so prevention is really not that difficult. It just takes some planning. And I'm not one of the folks that say, oh, you should be in zone 2 for all of your exercise, or have these kind of very, very rigid, dogmatic approaches. I think you should do what you want. If you like playing pickleball, that's a great way to be active. Go play pickleball. If you want to walk your dogs, go walk your dogs. I do recommend polarized sunglasses, but that's from the migraine person in me. But that's another topic. But do what you love.
Right. And just to hammer on this a little bit, when I think back, when I was in training and we talked about Alzheimer's and looking at risk factors, and it was age, age was a big one. education, the older you get, the chances of you getting, I mean, these are all, I was raised in this, right, from neuro. And then it came down with sex. Sex started to come in a little bit, but not really. Sex differences wasn't being highlighted as much. And then it came race, ethnicity came in the picture. All those things were like, I can't change any of that. This is what you can change. And I tell people, you can change these things. And when the cardiovascular really started to come in the picture, people got a little bit excited. Oh, I can. Yes. You're going to talk to your internist. You're going to talk to your cardiologist, and she's going to be looking at what your lipids look like. And in the cardiology suite, they're looking at that. And that helped me when I'm working in cardiology with the team. It helped me talk to people about their brain health because cardiology or the internist, they were monitoring the sugar. They were doing those things that we know are important for brain health. So people started to say, okay, I got that. So that's my first thing about prevention. You have to frame it as, no, this matters and it's good.
Can I pick up just,
please.
I'm sorry.
Yeah.
I think it's important that we have reached the point where sex and gender does matter in terms of research. And we have to be able to tease out the differences across diseases because go to cancer, go to heart, they disproportionately impact women. I'm sorry. Disproportionately impact women. And I think we need to begin to tease that out, especially related to the brain as well.
Absolutely. And talk about it in terms of that, right? And, AMWA has always done that. But I can tell you, Meryl, you know this. Even in our papers, very rarely are we stratifying the analyses to show the sex differences. We're not doing it enough, but we need to do much more. I agree.
All the economic studies that were done by RAND across the diseases that impact women, brain, heart, cancer, autoimmune, women are 80% of autoimmune patients. Small investments by NIH.
Right.
If they increased it slightly, the ROI was billions of dollars.
Exactly.
That's how small that focus is. So we have to change that. And I think there are initiatives to make that happen. Women are waking up. It's now or never.
Dr. Agarwal, I know you do a lot of research in this space. We're getting a ton of questions about Alzheimer's diagnosis and treatment in recent years. Any new developments? What's coming down the pipeline? What should folks know about?
Well, there's a lot coming down the pipeline. And I think the first thing, again, for the clinicians who are listening, obviously the drugs that have come to market after a drought for many, many, many years and failed clinical trials that were getting very depressing to report out to people that another trial did not meet its endpoint, which was cognition for most of the trials. So we have these new drugs that are, I'm going to say, not pill drugs. These are not orally, taken, which we are used to prescribing, the typical acetylcholinesterase inhibitor type drugs. These drugs are targeting amyloid in the brain. Okay, so they are what we are going to say a very direct kind of a targeted drug. They are, lecanemab, aducanumab first came out, then lecanemab, donanemab, the MABs, as doctors call them, monoclonal antibodies, and they're terrific. They have made some really important strides in what we're looking at. Number one, you can see these drugs being administered and you can see the amyloid being reduced in the brain on a PET scan. And that for a researcher and for looking for evidence, that's really strong evidence. Where the area continues to be discussed is the clinical relevance. Are there changes clinically are we seeing in people that the drug is directly going to influence, and is the risk profile appropriate for people? And this is what Leah goes back. Everybody wants to know a little bit about their risk, and they handle things differently. Many patients also want to know about the risks of these drugs and how these drugs could impair, let's say, not only their overall health, but their brain health in the form of potential edema, hemorrhages in the brain in certain cases. This is where the discussion is a serious discussion before starting drugs. And everyone has to take a pause and understand that these risks do occur. Now, I can tell you, the good news is they've been IV infused in the past. The frequency has changed. So it used to be very, very regular. Now it's going down in frequency. And now we're going into injectable, if you will. So you can see how it's trending, right? It's trending to having much more ease of use. And this isn't unique to Alzheimer's. MS has been doing it for years. Callie is working in migraine, and she's been looking at injectables for a long time. It's just the question of the profiles of who would be the right candidate to get the drug, and what are the steps needed for the testing before you could be considered for the drug, and then understanding the risk profile. So I think right now there's more coming down the pipeline. Regarding tau, we are looking at basically targeting tau, but we're not there yet. We're doing trials to understand this. And if you ask me how the treatment for dementia and Alzheimer's is going to be in the future, it's going to be a cocktail. It's going to be multiple drugs being used at different times, which again, nothing new to medicine. Cardiology knows it all too well, with different drugs being used for different aspects of disease. We do it a lot. But I do think this is where we're headed when it comes to active treatment.
Well, that gives me hope. It sounds like there's incredible work underway. So thank you to people like you who work so tirelessly in this space. Folks, we are getting so many amazing questions. We've answered some. Those we don't get to, we are going to try to address later after the panel wraps. As we begin to close here, Callie, would love to turn to you. Given your experience as one of the first clinicians that patients turn to, what would you encourage women to do if they have concerns about their brain health but aren't sure where to start?
Thanks for that. That's a tough question. That's an excellent question. But I think the first thing is, when you see a clinician, you want to make sure you have a relationship with them. You want to trust them. And I think that it's important to decide if you can trust your provider or not, and to find someone who works with you or who's willing to work with you. I think that's really important. You need to know them, and they need to know your preference, and that's what makes a good relationship. So trust is key. And I think it's important to as women, we're really good at expressing ourselves, but sometimes when people say, oh, it could just be stress, or oh, it could just be this, we kind of are like, okay, and we don't push it any further. If your cognitive concerns are bothersome to you, if you believe that something's going on, I think it's important to say, no, this isn't just stress. This is something else. This isn't me. We heard Leah say that when she realized something, this isn't me. And I think it's important that we push it, and we trust that person, and within that relationship, they'll be able to work with you as the patient to develop a plan that's suitable, that helps you to better understand what's going on, if that's baseline testing, and then kind of the long-term look of that and what follow-up will look like and things along those lines. But I think it's important that communication's open, and we don't settle for, oh, it's just stress, or it's this. If we feel like this isn't us, we need to advocate for ourselves.
And sometimes put ourselves first for a change, right? Dr. Eckerwall, anything to add to that, or any final thoughts before we turn to Meryl and Leah?
Yeah, I think taking it seriously. When people come to you, and again, understanding, really stepping back and understand, it takes a lot for people to say, I'm off. This isn't an easy thing. Like, behind that door, when they say, I'm off, if you take it seriously and say, okay, well, we need to talk about this, people just have an exhale. Okay, you're going to listen. Yeah, talk to me. And I'm going to ask questions to figure out, let's see how things are going. So this is why I'm asking you. I always start that off. I'm asking you this because I'm concerned about that. People then are like, I get why you're asking. You're not just being probing. Okay. Now, I do think, though, when people are coming in, we have these baseline screeners that can be done in the offices. Okay. A MOCA can be done in the office. A lot of doctors are doing that MOCA. Just by even doing that, people begin to trust you a little more. Like you're actually taking it seriously. So actually have an action thing to do. Okay. So that can be done, because the offices are busy. Okay. Very, very busy. So they can do that. And then the last thing is, I am, and this is just again my training, I'm always talking about clinical trials and registries where people can sign up and get in a registry and then have that registry do some digital testing on them. And then over time, if they notice changes, you may get a ping. People like that. Oh, there's something I can do. Yeah, we're going to keep working on it here. But in the meantime, there are these things that are out there that you should read up on. And there's a registry that you can sign up on, or there's a trial. Offering options as you start this discussion about brain health and start to build the process, I think works very well for a lot of people. And then they'll come back and share more with you. And then you're able to do more. As Callie said, once the trust is there, then you're able to do more things with people because they understand where you're going.
Meryl, looking ahead, what changes would make the biggest difference for families navigating the diagnostic journey, and how can each of us help move that progress forward?
That's the $64,000 question. Um, I think family members, you have to trust your instincts. For women, you have to trust your instincts and really push and persist about something that you're observing. And I used to write up my observations and take them with me to the doctor as one strategy. And to clinicians, I really say that the caregiver is a wealth of knowledge. Nobody taps into it. So fast forward to the future, wire us both up, right? Take the clinical into the home where people are and get the data. Don't trust what I say. Trust what the data says. And I think we have to think forward, but we're a wealth of information that gets lost because no one asks.
Leah, final question is for you. So, what is one message for women in the room right now who are worried about themselves or someone they love when it comes to cognitive health?
Did you say one word or one thing?
Oh, one message. Sorry,
Okay.
not one word. That would be difficult.
Yes. Think of yourself as a partner to the provider who is the expert. They're the expert on the disease. You are the expert on your body. And if you feel that you're not being heard, speak up. If I have something that I do often, and it's very successful. When I get down to the bottom line about what I might do, I'll say, if this were your grandmother, what would you advise? And then I trust what I get back.
Wow, that is so powerful. Clinicians, listen up. Thank you so much, Leah, for sharing your personal story. Thank you to all of our panelists for your incredible insights. Thank you to the American Medical Women's Association for hosting this event, and thank you to our sponsor, Eli Lilly and Company. Many of you have asked, and yes, the recording of this event will be made available on AMWA's website. We encourage you to share it with loved ones who also want to learn more about cognitive health. In the chat and in our post-event email, we've provided a handout with some key resources for clinicians and patients on this very important topic. Thank you all so very much for your time, for attending. Take care and be well.